Greetings from the 44th annual meeting of the Society of Gynecologic Oncology here in Los Angeles, California. My name is Brad Monk. I'm a gynecologic oncologist from Phoenix, Arizona, and I am very honored and pleased to be with my friend and colleague, Dr. David Miller, who is also a professor of gynecologic oncology at Southwestern Medical School in Dallas, Texas. Welcome, David.
Well, thanks for having me, Brad.
My pleasure. Yeah, it's great, and I know you're busy at this meeting. There's a lot going on. I don't know if it dawned on you, but it's your anniversary. You've basically been chair of the GOG Uterine Committee, Endometrial Cancer Committee, if you will, for a decade. Congratulations. I'm not saying you're getting old, but it's been 10 years, and we appreciate your service.
Well, it's been very fun. My very great pleasure to be of service where I can.
It's great. So I'd like to begin our discussion by talking about the treatment of metastatic disease. What happens is, you know, women with endometrial cancer, uterine cancer, generally get a hysterectomy, and occasionally they recur. And in fact, even when they don't recur, sometimes it's already metastatic. And in both settings, chemotherapy is indicated, either when it's already metastatic or when it recurs. And you were the principal investigator of a study that was recently presented, not yet published, called GOG 209. Tell us about what the study design was and what your conclusions showed.
Well, GOG 209 built on the previous results of GOG studies, most importantly in the prior study, which was GOG 177, where we compared the addition of paclitaxel to our prior best treatment regimen for advanced endometrial cancer, and that was with doxorubicin and cisplatin. So we sought to add paclitaxel to it because that had been shown in our phase 2 trials to be an active agent against endometrial cancer. We'd done a phase 1 study that showed how we can combine those 3 drugs, and so we did GOG 177, and for the first time showed a survival advantage for multi-agent chemotherapy in endometrial cancer. And
with growth factors?
With growth factors. It's a tough regimen, 2 days, lots of interventions, but it added to survival, so that was an important addition. The reality is that many people in the community already had lots of experience with another regimen which they perceived to be very similar. They've got carboplatin and paclitaxel. We use it for ovarian cancer all the time. People are experienced at giving it, and we asked the obvious question, could just the 2 drugs of carboplatin and paclitaxel be as good as the 3-drug regimen, the TAP regimen? And that was the basic question of 209. Was carbotaxol as good as, and could it replace TAP? And so that was a question in 209.
And TAP was cisplatin, doxorubicin, and paclitaxel.
That's right.
Okay.
That's right. With growth factors.
Right.
2-day regimen. So it was a little more complicated. And so we did what you needed to do. We did the randomized phase 3 trial, looking at survival as the outcome to make sure that if we did this less intensive regimen that nobody was going to be harmed. So we had a couple index toxicities we looked at, febrile neutropenia, peripheral neuropathy, which had been a problem with the TAP regimen. And so we finished the study in 209. The results have recently matured. We had an interim analysis. And so the bottom line is we found that carbotaxol is not significantly inferior to TAP. We looked at our index toxicities, which was febrile neutropenia. That was 7% in the TAP regimen, 6% in the carbotaxol regimen. That was a wash. When we looked at peripheral neuropathy, for TAP it was about 26%, which is significantly greater than the 19% that we saw with the carbotaxol regimen. Interestingly, that was higher than what we anticipated. When we looked at the activity of the regimen, we had patients with non-measurable disease as well as patients with measurable disease. When we looked at the patients with measurable disease in terms of response rate, that was 50% in both arms. So that appeared to be equivalent. We looked at progression-free survival, and that was about 13 months. Median progression-free survival was about 13 months in both arms, so no significant difference there. And then when we looked at overall survival, that median overall survival was 40 months in the TAP regimen and 36 months in the carbotaxol regimen, which was not significantly inferior.
It's practice changing though. So taking an
Clearly.
inconvenient and quite honestly a toxic 3-drug regimen and then showing that carboplatin paclitaxel can replace it. So that's game changing, and you're to be congratulated that the response rate is 50%. So part of the perception out there is that endometrial carcinoma is not chemotherapy sensitive.
That's
and in
correct.
fact, the perception is, oh, I got to give these patients hormones, MEG-ACE or tamoxifen, MEG-ACE or an aromatase inhibitor. And I think most of us that see these patients really prefer chemotherapy first in a fit patient because you got a response rate of 50%.
Exactly, exactly. We've not come close to that, even in hormone receptor positive patients using any type of hormonal therapy. There's a role for hormonal therapy, but we don't have anything to suggest that hormonal therapy is better than chemotherapy for most patients.
So doxorubicin was in the 3-drug regimen. You basically eliminated in the carboplatin paclitaxel arm. Does doxorubicin have any role now in endometrial cancer?
That's a very good question. That's a very good question.
That's why I asked it.
And we know that, for example, the liposomal doxorubicin is not very active in endometrial cancer when you give it frontline setting or in the salvage setting, second-line therapy. So, we don't have any suggestion that it's any better than the regular doxorubicin. So we're not really going to I don't know what to tell you about that. I do know that there is a study coming along with a doxorubicin that's bound to LHRH.
Right.
And so that company is very interested in evaluating their agent in that space, in that second-line setting. And so a study will be forthcoming that perhaps can address that question for us.
So I get asked all the time, as do you. So a patient will get carboplatin paclitaxel. You've established that as the global standard now. And those patients, at least in the metastatic setting, the recurrent measurable disease setting, are ultimately going to recur. In the adjuvant setting where they're metastatic disease, some of those patients will be cured. But in the recurrent setting, bulky disease, they're not going to be cured. What do you do when they fail carboplatin and paclitaxel, in lieu of what you just said, that liposomal doxorubicin or naked doxorubicin is not that great?
Right. Well, most things aren't that great. So you get to ifosfamide, which has about a 10 to 15% response rate, just like doxorubicin in this setting. You can look at bevacizumab. So that has about a 13% response rate. So we have a number of things that aren't great, but there are things to offer patients.
And I think it's also important to mention that this is agnostic to cell type. So about half of these tumors are non-endometrioid types.
Right.
So I get a sense that when the oncologist sees, oh, this is a serous tumor, that this patient needs to be treated differently, and all the things that we just talked about are not relevant. The reality is that those serous tumors are actually a large proportion of what we're talking about, and indeed very relevant. And in fact, the endometrioid tumors, many of those are poorly differentiated and may have a similar biology.
Right. So about half the patients were endometrioid. Most of those were poorly differentiated.
Right.
But when we've done an analysis looking at various tumor subtypes, we don't see any significant advantage for one regimen over the other based on any of these histologies. So we don't have a signal yet that we can break things out based on histology and treat them differently, because we haven't identified what the different treatment is.
And I also like what you said, that bevacizumab is active in this tumor. So it's kind of strange. So we're all familiar with the ovarian cancer, 4 randomized trials that are positive. I already spoke with a cervical cancer expert, Krish Tiwari, who says that it has a survival advantage in recurrent cervical cancer.
Yes, that's a very big announcement.
And now you and others want to add it to carboplatin paclitaxel in metastatic endometrial cancer.
We've already done it.
So that's and so here at this meeting, at the 44th annual meeting of the Society of Gynecologic Oncologists here in Los Angeles, they just tell us what they did.
Well, first you should be aware that the GOG is already ahead of them, that we did 86P, which was a randomized phase 2 trial looking at several different regimens of chemotherapy combined with a targeted therapy in hopes to select one that we might be able to bring forward in a randomized phase 3 study. So there was 3 regimens that we looked at. That study's concluded. We're awaiting the results. So that was paclitaxel carboplatin with bevacizumab with the chemotherapy and then maintenance after that. We had carboplatin paclitaxel with temsirolimus with the chemotherapy and then a maintenance after that. And then carboplatin ixabepione with bevacizumab and then bevacizumab maintenance after that.
I need results from that trial, though. That's a great trial. So since
Exactly.
since you don't have any results for that,
We
we
do not have
got to
one.
talk about a single-arm phase 2 of carboplatin paclitaxel bev, which wasn't compared to anything, and I don't know what it means.
Well, exactly, because they concluded it was a negative trial, but they thought further evaluation should be done.
So I guess the thing that we know, I think we know for sure, that in a patient with endometrial cancer, that single-agent bev does have a level of activity, and that it can be added to carboplatin and paclitaxel like it's added in other gynecologic cancers or lung cancer, let's say.
So the Ohio State group used it in, since they participated in 86P, it's not quite clear exactly what the population was, but it looks like it was patients with no residual disease who had evidence of spread beyond the uterus. And so it was a pretty well tolerated treatment. Their febrile neutropenia, it was all comparable to what we saw in 209. Their median progression-free survival was about 26 months. We haven't drilled down exactly in the 209 population, but it was about, we had about a 60% progression-free survival at 2 years in 209 in sort of that no residual disease adjuvant therapy population. So, you know, their bar was a 70% progression-free survival, which I guess they were expecting some pretty stunning results.
Right.
But nonetheless, we at least don't see any evidence to suggest that it's bad. There's a suggestion that, you know, that it might, you know, that a bevacizumab might add something, and particularly again when we look at maintenance.
Right.
And I'm kind of suspicious that that's where we're likely to see the benefit, and particularly when we look at some of our other tumor types.
Right. So I try to teach people that epithelial ovarian cancer is probably 5 diseases. It's the chemotherapy-sensitive diseases, the high-grade serous, and the poorly differentiated endometrioid cancers. And then there's the mucinous and the clear cell and the low-grade serous tumors. And it's been really interesting that in that low-grade serous population that there's a number of RAF, RAS, MAP kinase pathway perturbations, and MEK inhibition is probably a nice way to interact with that pathway. And so you're hearing a lot about MEK in gynecologic cancer. So at this meeting, I guess they wanted to also study it in endometrial cancer. And, and so as a single agent, just like in low-grade serous ovarian cancer, they studied it in endometrial cancer. And what did they find?
Well, a little background. We have to understand what the reality is. The reality is that we're, companies and industry is getting more interested in endometrial cancer, but still not very interested. Right. So we sort of have to take what we can get and take advantage of opportunities to study things. The other thing is, every meeting I go to, some targeted therapy is presented where the targeted therapy worked not in the patients with a target. I mean, it's every meeting. Okay, so we can call out the emperor's new clothes.
Right.
So I think it's not like we have a long lineup of things that we can test. We have a short queue, and we're going to evaluate everything that is reasonable. So Rob Coleman looked at in our 229 series in the GOG, looked at AZD, whatever the number is.
6244.
Excellent. MEK inhibitor, MAP kinase pathway. Unfortunately, there's only about a 6% response rate, only about 20% free disease at 6 months, and so that didn't quite meet our moving bar, because with bevacizumab, with aflibercept, our bar is moving up. We're making some progress on particularly that progression-free at 6 months bar. So by our criteria, this was not an active study.
Okay.
You got a platform presentation out of it, but not active.
So let's talk more about who these patients are with endometrial cancer generally, and ultimately who they are when they get a recurrence. It's clearly not a secret that obesity is a risk factor for endometrial carcinoma, that the adipose tissue aromatizes adrenal androgens and ultimately increases estriol and other estrogens to cause proliferation and ultimately mutations in endometrial carcinoma. So I've always wondered, if this is the population, what's the risk of second cancers down the way, because obesity is a risk not only for endometrial cancer but for other cancers. And also, importantly, why don't we try to help them lose weight?
Exactly.
And so there were two abstracts, very interesting, that addressed both of those. Let's talk about the first one. It's a trial that was called the SUCCEED trial. Self-efficacy, quality of life, and weight loss in overweight or obese endometrial cancer survivors. Small little randomized trial, 75 patients. I love it. What do you think of that?
Well, I think it was great because, recall that when we look in our adjuvant endometrial studies, more patients die not of cancer. They die of other diseases.
I got to repeat that. So if you have a patient that's 55 or 50 and weighs 350 pounds and has a Da Vinci robot hysterectomy and doesn't have metastatic disease, moving forward, the chance that she's going to die of another cancer or of an obesity-related complication is higher than getting recurrent cancer.
Exactly.
So when I see that patient in surveillance, which we do, for reasons I'm not clear, but we do, I talk about her weight loss, her colon cancer risk, her breast cancer risk, her blood sugar, her hypertension, because that's really those
are the important things.
Those are the important things.
Well, I mean, we are the victims or the victors of our success. More patients are living with cancer, and so we and doctors who don't take care of cancer patients are intimidated by them, and so it really falls to us to look at the whole patient and their problems as a consequence of their disease.
Right.
Their disease may have arisen as a consequence of their various medical problems.
Right.
But I think, it's our obligation that, if we're going to really help these patients, we have to look at them as a whole patient. And you go to the patient, and she's had endometrial cancer, and it's early endometrial cancer, and I'll tell them, they ask me, are you going to die? I said, yes, probably not of your endometrial cancer. You're probably going to die as a consequence of some disease related to your obesity. So maybe we should start working on that problem. And so what the group out of Vivian von Gruningen's group showed very nicely in a small little study, lots of these quality of life measures, but the important thing was they showed with just a little regimen of counseling people about nutrition, how to diet, get some exercise, give them some love, show them some attention, that it worked.
And they lost weight and felt better.
They lost weight and felt better. Okay,
prospectively. I love it.
At 6 months and at 12 months. So, to me, that's very encouraging. In fact, the more weight you lost, the better you felt.
Right. I love it.
And so, to me, that's very encouraging. We'll have to see if that actually has an impact on survival. We certainly expect that it should.
Right.
But clearly, it shows that we can make a difference.
I think that's
insightful. So we need to start trying to do that.
And then the other paper was a paper that talked about second cancers, and really what you would expect, that the cancers that these women get are the same cancers that are most common, GI and breast cancers. But importantly, if you have a personal history of endometrial cancer, that your risk is higher compared to the general population. And that risk was not entirely related to Lynch syndrome.
Right. Because again, I think our understanding of genetically related cancers is incomplete.
Right.
And I think there are probably syndromes that we just haven't figured out yet, and they've showed that not every of this extra number of colon cancers they found, they weren't all accounted by Lynch syndrome patterns. So I think there's going to be other things that we'll eventually figure it out. But clearly, you know, if you have a risk, if you get one cancer, we did a little study similar to this at our pace, comparing patients with other cancers.
Right.
And we also saw a preponderance of second malignancies with colon cancer, breast, compared to other cancer survivors.
Right.
So there's a difference between what your index cancer is and what your other malignancies you might be related to.
And we're bringing this together. So we're talking about obesity. We've already talked about targeted agents. One of the obvious strategies would be to use metformin, both as a glycemic control drug, but also maybe as an anti-cancer drug because of its interaction with the mTOR PI3-AKT pathway. And I think you're doing that, right? You're adding it to carboplatin paclitaxel.
Yes, we are.
That's the next study, right?
Yes, we are.
Tell us where we are with that.
Well, it has been approved by all the appropriate regulators in spite of the fact that it's not an expensive agent. It's not particularly glamorous. One of the reasons why you go back with the product and see what its effect is, and that's how this came to light, they noticed that, gee, patients taking metformin for their diabetes, gee, they had less cancer.
Right.
Maybe there's something here, you know,
Right.
and it has other effects. And we also know that living in a bath of too much sugar is bad for lots of things, and it's probably bad for cancer as well. So Vicki Jump designed a very nice study. She did the background laboratory work to show, just pretty consistently that where metformin is, it can have a
Anti-cancer effect.
Anti-cancer
as well
effect.
as a glycemic effect.
Yes, and so now we're doing the next obvious step. We take our best chemotherapy regimen that we were going to be able to combine something with. You know, TAP may be a little bit better, but it's very difficult to combine anything with TAP, so we use carboplatin and paclitaxel, combine it with metformin, and so that's going to be...
Versus placebo, carboplatin, paclitaxel. Does that study have a number yet?
That is a 86 study, and I don't know what its number is yet.
And it should open...
Hopefully within the next 6 months or so.
And then our last point of discussion, we've talked about obesity being a component here, but age is also a component. So patients that are over the age of 70 are a much different population for lots of reasons. And so the Gynecologic Oncology group looked at their laparoscopy study. It's called LAP2, the study that showed that you can have minimally invasive surgery, and you should, to have your hysterectomy for endometrial cancer, and looked at that group and looked at the older patients older than 70 and showed a number of interesting things, so that the complication rates were higher, okay, but they also had high risk factors. Tell us.
Well, they had, it seemed like the younger patients had what we call the type 1 endometrial cancers, the well-differentiated ones, the ones that we blame on hormones and obesity. And these patients over 70 appeared to have more of the type 2 endometrial cancers.
Poorly
high-risk,
differentiated,
high-risk histology. They were also more likely to have lymphovascular invasion, lymph node metastasis, a higher stage. And we had sort of seen an inkling about that when we looked at the prognostic factors out of the PORTEX study, out of GOG 99, and age kept popping up as a risk factor.
Right.
And I think it is sort of a surrogate that you're
biology.
likely to have a different type of tumor.
But this study showed that although all those high-risk factors were present, less than half of them got indicated adjuvant therapy.
Well, we can talk about whether that's indicated.
Tell me.
Well, because that's one of the things we're trying to do right now in the Corpus Committee is figure out who needs adjuvant therapy, because the benefit from our adjuvant therapies, most typically some form of radiation therapy, it does a pretty good job of eradicating or preventing the cancer where you irradiate. It doesn't do that very good of a job of improving survival.
But that's why if it's in the lymph nodes, the standard of care is chemotherapy. Okay. But if it's not in the lymph nodes, there is a temptation to give radiation, but that doesn't improve longevity.
We're going to define that in GOG 258
That's right. That's the fun of it.
because you know, it does pretty clearly help if you know there's cancer there. The issue is radiation therapy given to people without cancer doesn't help them.
But you'd agree that if it's in the lymph nodes, that chemotherapy is indicated.
Something should be done.
Something.
And we're going to determine whether radiation needs to be part of that equation.
But if it's not in the lymph nodes, then it's controversial.
Then I have serious questions about, you know, whether, again, giving radiation therapy to people who don't have cancer is not going to help.
I understand.
So we want to better identify the patients who are more likely to have cancer. So we're working on a lymph node trial, and we see, because we know, and that's what this ancillary data study from the lab 2 in these older patients, you know, doctors are speaking. You know, why didn't these patients get adjuvant therapy? Because they were older and people were concerned about toxicity,
right,
knowing that so far all of our common adjuvant therapies, brachytherapy, pelvic radiation therapy, we don't yet know for sure about chemotherapy, but at least our radiation interventions don't add anything to survival in node-negative disease.
Listen, David Miller, it's been my pleasure. Very stimulating. I think we've done very well in establishing really what the standard of care is when the nodes are positive or it's recurrent. Talked about adding targeted agents in that setting as well, bevacizumab. Talked about some of the high risk factors, obesity and age. It's been great. Thank you. I appreciate you finding time for me today. This has been Best of the Day from the Society of Gynecologic Oncology. So long for now.